Le Dr Stephen Liben est professeur de la faculté de médecine de l'Université McGill et directeur du département de soins palliatifs de l'hôpital pour enfants de Montréal depuis 1995. Il a collaboré à développer et enseigne une approche médicale en pleine conscience, mindfulness, comme partie de son travail dans le programme Whole Person Care de McGill, une approche holistique des soins de toute la personne. So Dr. Liben is a professor in the Faculty of Medicine of McGill University, director of palliative care at the Montreal Children's Hospital since 1995. He has co-developed and teaches a mindful medical practice course to medical students as part of his work in McGill's Whole Person Care program. And Dr. Liben is going to talk to us about the future of palliative care with a question mark.
Thank you, Kathy, and thank you for inviting me. I'm going to walk around a little bit, keep people on their toes and keep me awake while I do this presentation. Just to get an idea of who's in the room, can you raise your hand if you work in healthcare? Okay, thank you. And if you don't work in healthcare? Okay. We'll see what the people who invited me think about this talk. I do want to thank them, particularly Kathy. Where are you sitting, Kathy? Where'd you go? Okay, right in front of me. She gave me complete freedom. I got to say, if you hate this talk, that's fine. You hate this talk because I made this talk. You can't be upset with her at all. It's not her saying it all. They gave me complete freedom. So I structured this the way I wanted to, for better or for worse. Now, number one, I've got no conflict of interest. I have to put that up there. No financial conflict of interest. I have all kinds of other personal conflicts of interest. I mean, who doesn't have a personal conflict of interest? And I hope one day to have a financial conflict of interest. God willing, one day someone will actually pay for this kind of stuff. But for now, I have nothing financially involved with this. So the talk is titled The Future of Palliative Care. And I think that's probably a poorly chosen title. At best, it's a future, or a possible future, right? I mean, I don't have the nerve to say what palliative care should or will be in the future. So what I'm going to present, and it's not a long presentation on purpose, is what I hope it will become, what I think we can strive for it to become. And I'll explain a bit of why and what we're practically doing about it to try and make that happen. Not just sort of hoping and wishing, but there's things we can do to create the kind of world we want. And we're living in a world, as we all know, where things are really difficult, right? Political things are difficult, climate change. It can feel overwhelmingly negative. It can feel depressing. It can feel like it's just unsolvable. And this vision or this idea, we'll see what you think, but I think we can do this. I think we are doing this, and our job is to keep going. So let's see what this means. So, this book. So Steven Pinker. How many of you, if you raise your hand if you've heard of Steven Pinker? Okay, so Steven Pinker is an author, Montrealer, and that's the cover of his book, Steven Pinker, Enlightenment Now, The Case for Reason, Science, Humanism, and Progress. It's a great book. It's a tough book. It took me months to get through it, chapter by chapter, because it's filled with data, because he knew people were going to argue with him. His major argument here is, backed up by data, it's not just he's saying he thinks this and that, is that the world is a much better place than it has been ever before in history. And he goes through chapter by chapter, a chapter on technological progress, a chapter on disease, and of course, I should say what I do. So I'm a pediatric palliative care physician. I do palliative care for children. Yes, I do palliative care for children. Who would choose to do such a thing? I've been doing it for over 20 years, and I think that his argument that he makes is that things are much better if you had... How many children do you think die per year at the Children's? Now, I have the physician from St. Justine over here. I just met her, so I know she knows. How many people do you think die? The Children's Hospital that I work at is about a 130-bed hospital, roughly, to give you an idea. How many, would one of you just take a guess as how many kids do you think die per year at that hospital? 300. You said 300? Yep. 300. Wow, that's a lot. Thank goodness it's not, but that's high. And when I ask people, I get ranges of people are surprised that any children die or that it's very rare kind of thing. So it's about 1 per week. There's about 50 kids per year. It's more at St. Justin because they're a bigger hospital. It's about 800 in Quebec. There's 5,000 per year in Canada. This is just the way it is, right? So, and we talk about the loss of a child as the worst possible thing that can happen. Maybe that's true. Probably that's true. We talk about it as a disaster. For sure it's a disaster, right? I mean, the thought of losing one of our kids, absolutely disastrous, right? People say it's against nature. I don't know about that. People have been losing children since man began and woman began. And in fact, one of the arguments in Steven Pinker's book, not an argument, it's a fact, is that childhood mortality has dropped tremendously. So that fortunately we're able to say now that you can expect your kids to live, to grow to adults. Most of us are fortunate, and it's rare that a child actually dies. But it does happen, and at the hospital where I work, it happens about once a week, to give you an idea of the kind of frequency of it. Anyway, so he pauses out. They've asked the question to people, you know, if you could live any time in history, when would you rather live? You know, who would rather live? Raise your hand if you could pick any time in history and you choose to live now. So some of you, right? It's like you have to think about that one, right? If you looked around the room, it was about maybe a third of people like not sure, right? You know, what was it really like back then? You'd have to want to know more about what you'd be going back to, because there's a romantic version of what we see on TV and stuff, and then there's the reality of being cold and hungry and sick and having infections and just having a toothache your whole life and dying from it. Like, it just goes on and on. You know, in terms of that quality of life, it's hard to argue that it was much better then. Even the kings and queens of 200 years ago didn't have the kind of life that we have, access to pain control and symptom control and the foods we can eat and the safety of the foods that we eat. We drink water, we expect not to get sick. Those kinds of things were totally not taken for granted just over 100, 200 years ago. So his book argues that we've come a long way, and there's no guarantee we're going to keep going, because people talk about the arc of history as if it's going somewhere preordained, which I don't believe there's any preordained, and neither does he. But we can help create that arc, and we can help continue to go things forward. So, so why did I put the book title here? Because I feel a kinship with Steven Pinker. What's the kinship? Why would I have, this guy's an intellectual giant. I am so not an intellectual giant. Well, our names are both Steven. He lived in Westmount growing up. I'm in Westmount now. Okay, that's 2. He's Jewish. I'm Jewish. Emphasis on the ish. Atheistic Jews, whatever that means. Still figuring that out myself. I wish I could write a book like him, and I can't write a book like him, but I can fake a book cover as if I did. So this is the title, this is the new title of the talk. I just made it up right now. I'd like to make the case right now with you that for empathy, caring, and whole person care is not just for palliative care, but for all of medical care. That we're actually aiming too low when we talk about palliative care. So I work in palliative care, it's my life's work, and yet I think we can do more than that in whole person care. So that's what I'll talk about here. So back when I still was on Twitter, which wasn't that long ago, as you can see, deleted my account, saw this tweet from a physician. Saw a new patient today who was transferring care to me. When I hear this, I usually ask what I can do to be the doctor they need. He said, well, you're listening to me now, so that's already an improvement. The low standards that we condition patients to have is alarming. And I think we do set our standards way too low. You know, when we have still the argument, you know, do you want the surgeon that can cut, or do you want the surgeon that can communicate with you? Well, what I want is not to have that question put to me anymore. I want a surgeon who's going to operate on my mother for her breast cancer to be able to look at her and tell her that he's there for her. He's going to be able to communicate with her, and I want him to be able to operate. I don't think this false dichotomy of having a surgical skill and being able to communicate should exist anymore. And our standards are pretty low. You've all had encounters with the healthcare system, I'm sure, I would imagine, and they probably all weren't positive. I went through many years of my dad being mentally ill and of showing up repeatedly with him at the emergency room at a hospital in the city where I don't work, trying not to name it, right? Trying not to name the hospital. And for years of showing up in the emergency room, I'd show up and it would always be kind of like a war zone, feeling that emerged, and people on the floor, and roasting chickens on the side, and like, what is going on in this place? Every time I would show up, and it would be like, the nurse would be like, oh yeah, we're having a really rough time tonight. And they said that to me every year for 25 years. And I felt for the nurses and the doctors and everyone else who worked there, but they saw it as a battlefield, and my father was a problem for them. He wasn't somebody to get care. He was a psychiatric patient. Nobody liked psychiatric patients in the healthcare system very much. Much more interested in something you could fix right away. You can't fix my father. He was unfixable, but you could help him, and he was helped. But it was an uphill battle, and the standards were so low that it was, if someone offered me a chair or asked me how I was, which happened once in 10 years, I was like, start to cry. I mean, I couldn't take it. I was like overwhelmed with gratitude, and I realized, why are my standards so low to expect so little from people? It was so rough, the treatment that went on there. And only when they would see that I was a physician, because somebody eventually would recognize me, because I've lived in Montreal forever, and with Dr. Liben, and all of a sudden everything would change, and I resented that. I resented that they had to recognize me for my dad to get the care. Anyway, so I have my own issues, obviously, right? Okay, so that's low standards is certainly a problem. This is a second tweet. This morning, a junior doctor on the ward, her opening sentence to me and my husband, what do you understand to be happening? Her closing sentence, is there anything else you want to ask me? And she says, I wanted to hug her, right? Those two questions, right? What do you understand to be happening? And then to be quiet and listen to the person. And then ending with, is there anything else you want to ask me? I mean, what could sound simpler? It sounds like, of course doctors should be doing that. How can they not be doing that? It's so obvious. And yet when I go with colleagues or when I walk in with students, it rarely happens. Usually it's, hi, I'm Dr. So-and-so, and they start talking and talking and talking and talking. And I don't even know if the person can understand English or French. There's no clue, and they're just talking away and talking away. Anyway, so there is hope for the future. We are moving in a better direction with things as simple like this, and I'd like to explain one way that I think it can happen, and that's the segue to this slide. So I'm part of teaching a course called Mindful Medical Practice, which, as I've told the students, it really isn't about mindfulness and meditation. We don't want to teach them to be meditators. That's not the point. We want to teach them to ask that question and then know enough to be quiet and let the patient talk back and not interrupt for the 18 seconds it takes usually for them to interrupt. So it's really about essential clinical skills. So McGill's one of the first universities where the students have to take this course to pass medical school. It is not an elective. So every medical student, there's about 180 of them, just before they enter into the part of training where they go see the patients, the clerkship, they have to take this course. It's 7 weeks, 2 hours a day, in a small group setting, with the same teacher for 7 weeks going through. Each 2-hour session has a particular topic. So one's on medical errors, 2 are on communication, 1 is on suffering, what is suffering, those kinds of things. So we go through this. So that's a example of sitting quietly and paying attention to the sensation of their breath for 3 minutes. Can they do that for 3 minutes? Can you be quiet with your patient for 3 minutes and focus on them for 3 minutes? Because what happens when we're listening to people, even now for many of you, you've drifted off what I'm saying, onto your list of things you're going to do later and all kinds of other things, right? That's normal. We're not built to focus attention like laser beams, but we can practice bringing our attention back over and over again and get better at that and strengthen that muscle. So we do that with the medical students here in the classroom. It's very labor-intense work. 180 medical students, it's a lot of hours of instruction. So that's one example of what we do. So here what you see them, I don't know if you probably can't see that well from the back, but there's groups of 2 and 3, and one of them is on their cell phone. So we go through an exercise where one is actually asked to tell an interesting story to the other one, while the other person is told to go on their cell phone and kind of, pay attention to the phone, look at your tweets and all the rest of it. They go through that, they switch roles, then we debrief that, we go through that, we talk about cell phone use. In the hospital, we talk about it. Instead of just giving them a lecture where they say don't use your cell phones when they see all the staff using them anyway, we let them experience for themselves, feel for themselves what it's like to be listened to and not listened to when someone starts scrolling through their texts and their phones. It doesn't generally feel very good, right? So that's this is the experiential learning aspect of it. And we have them discuss together and elicit for themselves the kind of learning points we have as a set curriculum. So that's this course that I think is some hope for creating the kind of doctors and the kind of medicine we want, not just as fellow doctors, but as I want when I get rolled in that emergency room. I want somebody that can also listen to me. Okay, So what's this idea of whole person care? I think I can explain it, I think, pretty briefly and pretty clearly. Let's see if this resonates for you. So we have the doctor, or the clinician, if you're not a doctor, clinician, right? And you have a person who has a disease. It's called a patient. So it happens the Latin derivative of patient is patiens, is the sufferer, right? So this is not news to anybody. A couple hundred years ago, patients, we didn't know what they had. We didn't know how to separate the disease from the patient. So when someone would come in with seizures, we'd say maybe they're possessed by the devil. Maybe they ate something wrong. We had no idea what they had. And not knowing what somebody has is very difficult. So where we are now in medicine is that we have a scheme where we've separated the person from their disease. So now you're somebody who has a seizure disorder. You're not somebody who has some weird thing where we think you may be possessed or it's somebody's fault. We can describe what that disease is. We can name what you have. And the power of naming is very important. It's important in all aspects of medicine. Being able to tell people what's wrong, that's no longer their fault. There's something, and there's often a treatment plan associated with that. There's something that we can do. Oh, thank goodness, I've been getting up and peeing every 5 minutes at night and I'm thirsty all the time. They come to the doctor and we come back with, well, you have diabetes. This is what diabetes is. It's not your fault. Here's the treatments and so on. So separating the disease from the person has become very, very helpful, right? But it also has created some problems. So the doctor has a relationship with the disease, looking at the microscope, figuring it out, what the differential diagnosis is, doing blood tests, looking under the microscope to see if it's leukemia or if it's some other kind of anemia. That kind of relationship is about curing patients. It's about holding on. It's about maintaining the status quo. It's about fixing what's broken. And when things can be fixed that are broken, what do we want? We want them fixed, right? Don't you? Your leg's broken, fix my leg. Although the surgeon doesn't actually put your bones and fix them, he puts them close enough together that they heal themselves. But in any case, you want what can be fixed to be fixed. And there are some things in medicine that can be fixed. There are cancers that can be cured. There's infections that can be cured. But as most of us know, most of medicine isn't curing things 1, 2, 3, or even ever, right? Kind of a myth. Most of our time is spent with patients where we make things a bit better, and they get a bit worse, we make them a bit better again. We're not actually fixing things often, as often as we'd love to see on TV. And the problem with this relationship is if the doctor thinks that's the only relationship that matters, then they end up saying things like, I'm sorry, there's nothing left that I can do, right? That's when they run out of treatments. I run out of treatments, I can't cure the illness anymore. I'm sorry, there's nothing left I can do. Kind of like a pilot on an airplane who you would hopefully never see putting on a parachute, opening the door and saying, I'm sorry, but there's a problem with the engine, I'm out of here. And just jumps off the plane and leaves the passengers alone. There's a relationship here that involves two people being together. And that involves healing people even as they're not being cured. For those of us in palliative care, we know this sort of weird dichotomy that people can become healed precisely at the time when curing is no longer possible. There's something about being very ill that breaks open the capacity to be able to heal. And I'm not saying that doctor actively heals, but what we can do is create the conditions where healing can happen. In the same way that the gardener doesn't make the plant grow. You plant the seed, but you don't every day dig up the seed and pull it up to get the green stuff to come out, right? You create the conditions for growth to occur. You make sure there's enough light, you water it every day, you put fertilizer, you keep the parasites away. And palliative care, I think, is similar. We take away things that are going to cause harm, pain and other symptoms. We try and create an environment where healing can occur. And people can die whole. That's not a new message. This is an old message, right? From Dame Cicely Saunders and others. So it's about focusing also on that relationship, the doctor-person relationship. And what we're seeing with medical students is there's also a bit of a fracture between the doctor and the person. So the medical students come in as people with no skills. We give them skills, they establish a professional identity, they see themselves as doctors, and they often have a difficulty coordinating that professional identity with what they are. And that schism, if you remain separate from who you really are when you walk in the room, if you don't bring in your own humanity into the room, it's sort of a recipe for burnout. If you're kind of faking it, that you're some of this professional that either doesn't feel anything. So reintegrating the person with the physician person with their professional role together is another form of healing for the physician themselves, who also need to become whole and reintegrate again. So the whole, it's a kind of a complicated schema in a way, right? There's two people. The person has the disease. A person with the disease, we say, is having an illness experience, the difference between the word illness and the word disease. Illness is what happens in a person, right? And you have a physician who's got a professional identity. And it's about holding all this together in a particular kind of awareness. Kind of awareness we talk about is mindful awareness that we practice with these students in this course. And I think well, we'll get to that. So what we don't talk enough about, and I think it's particularly important when we talk about medical aid in dying, because in the law, as I just heard before, Dr. Binet talking and others, we talk about intractable suffering, right? That's in the law. If someone has intractable suffering, they can get medical aid in dying. Yeah, but what is suffering? Like, what do we know about suffering in medicine? We don't know that much about it. We just say it's just a word that everyone's supposed to know what it means. And if we say someone has pneumonia, and I ask a medical student, or I ask one of the physicians in the back that I know, that I won't ask them, don't worry, Dr. Fleischer, Dr. Russell, I won't ask you. If I ask for a different, and they know the answers. If I ask them differential diagnosis of pneumonia, they come up with a whole taxonomy of pneumonia. There's bacterial pneumonia, viral pneumonia, bilateral pneumonia, and so on. But if I ask physicians for a taxonomy of suffering, what are the different kinds of suffering? What kinds of suffering are treatable? What kind of suffering is not treatable? What are the different treatments for it? You don't get much of an answer. It hasn't been well studied at all. And it's amazing in medicine when that's all people, we're really a suffering center, we're not a healthcare center. People don't come to us and say, hi doctor, I'm having a great day, everything's fine, bye. They come to us with their problem, right? They come to us like this. Help me with my problem. And when I go to my doctor, it's the same thing. I'm like, help me. Like, there's something, I'm suffering, right? There's different kinds of suffering. We haven't even explored what that means. Eric Cassell did some of this work on exploring suffering back in the late 80s. The Nature of Suffering and the Goals of Medicine. There was a New England Journal article, medicine article, there was a book, but there hasn't been much more work done on that. And what he defined as suffering is anything that threatens the intactness of the whole person. So there's no need to conflate pain with suffering. They're not the same thing. Can you think of an instance when you can have pain and not suffer? Can anybody think of a time when you might have pain but actually not suffer from the pain? Childbirth, yeah, so I'm told. So that's a good one, right? I think so, right? If you're exercising to run the Olympics, you're going to feel pain, right? But it's not necessarily going to suffer from it. You expect it. In fact, you actually see it as a positive thing. So pain and suffering are separate concepts, and suffering has its own taxonomy as well. So here we have a gentleman who's holding onto his rock. My stone, I don't want to give up my stone. It's not much, but it's mine. I can't live without my stone. On the other hand, you see he's in water, right? So if he doesn't let go of that stone, right, what's going to happen? He's going to drown, right? Right? What? What, sorry? He'll lose his stone, right? Right. So what's the stone? Previous identity. Absolutely. Previous identity. And what might be something that you see that people hold on to that they don't want to let go of in their previous identity? Can you give an example of one thing people don't want to let go of? Overeating, yeah. You think of an example of someone at the end of life who doesn't want to give up a certain idea of I need this stone to be happy. I need this stone to live. Without this stone, how am I going to be the person I want to be? Autonomy, right? I think autonomy is a very good one, right? So if I have to wear diapers, right, I'd rather die than wear diapers, right? There's dignity. So when we throw these words dignity around, I think that there's nothing wrong with the word dignity. It's just that it's not a static concept. Because we know that people, us, are poor predictors about what we're going to want. So if you ask 100 healthy medical students, would you rather be dead and be killed, or would you rather, if you were going to be quadriplegic, or would you rather want to live as a quadriplegic? So most medical students will answer in surveys, and they have, that they'd rather be dead than be quadriplegic. But if you look at 100 quadriplegic patients who are in that same age group, the vast majority of them have adapted to their quality of life to the same it was before, after like a year afterwards. So that's something called response shift in psychological literature. So we're not good at predicting how we're going to feel later. We think we are. If I ask you, how would you feel if you won $10 million in the lottery? You're going to tell me you're going to feel great. And I say, a year later, how are you going to feel? You're going to go, it's amazing. Are you a year from now? Are you kidding? That'd be amazing. I'm going to be thrilled forever. They've studied that. People go back to their baseline level of happiness. Actually, they do worse. Most people do worse winning the money. They actually are more miserable after they've blown through it, a lot of it. And so, but all of you feel that you're an exception. I feel I'm an exception. Give me 10 million, I'll be flying high forever. But I probably won't, right? A part of me knows it's not true. So we're very poor predictors about what we need. And we hold on to our stones. We hold on to our stones. And I just think in this world, in this age of medical aid and dying, how much do we even know about how to work with people about letting go of their stones? Because healing's about letting go, right? From the other diagram, letting go of the stone. And how much healing is there in letting go? And how can we help people let go? And hold on to what really is important to them. Okay, and not tell them what to let go, but to work with them, to find their own meaning. I don't have answers to these things. I think these are unexplored questions that we need to explore more. So one thing was suffering. We've got to talk about something more positive than suffering here, right? So compassion and empathy. So empathy is when you feel what somebody else is feeling, but you can not necessarily want to do anything about it. Compassion is when you experience the emotion another person's feeling and you have a desire to act on it. So that's what we want to inculcate in ourselves for our patients, speaking as a physician, and in our medical students, right? We want them to be compassionate. We don't want them to just feel along and feel bad with their patients and not do anything, right? You don't want to go to your doctor. It's nice to have them feel bad with you, but you want them to do something. Do what can be done. So compassion is more than that. And people talk about compassion fatigue. I put that up to remind myself. Compassion fatigue, right? So real compassion is a form of, can I say the word in here? I don't know if it's allowed. Anyone from the faculty here? The L word, love. Okay, so I just said it, okay? So it's kind of a form of love, right? Love and loving, right? Non-sexual loving, right? Nothing wrong with saying that. So what fatigues? Your compassion doesn't fatigue. Your love for your kids doesn't fatigue, right? What fatigues when you're dealing with your kids or with somebody is when they don't do what you want them to do, right? That's what's irritating. So you have compassion for your patient, you tell them to do this and this and this, and they don't do the this and this. They do something else, and things are much worse. If they come back and they haven't done what you've told them, and you're aggravated because it hasn't resulted in the outcome you expected, what you have is attachment to outcome fatigue. Your attachment to the outcome is what is exhausting you. The same with your kids, right? When they don't do, anyway. So it's attachment to outcome fatigue, not true compassion fatigue. Your true love, true compassion, the act to help others, that doesn't fatigue. But it can be exhausting when you continually are being let down because you're not getting your expectations met, okay? So compassion. Now, language is power, part of the diagnosing thing. When we don't have words for things, we're lacking power. So if you don't have a word for a diagnosis, you're sort of stuck with things. If there's no words, so these are the kinds of words that were brought up a bit here that we throw around. I think we need to learn a lot more about what these things mean. And the way we know a lot about pneumonia and different kinds of antibiotics, we should be learning about different kinds of compassion, for example. So I'm not going to belabor you with the kind of work that's been done. There hasn't been a lot of work done, but there's some work done. This is from Joan Halifax, who works out of New Mexico in Santa Fe. And she's created sort of a taxonomy. So taxonomy means sort of like a list of the way things can be separated into different parts. Instead of just saying compassion, you can take a look at different ways of looking at compassion. So one way is compassion in reference to somebody else, referential compassion. So one kind of referential compassion, you all understand what this is biologically based. You can be compassionate towards those that you actually have a biological bond with, right? Like your kids, or your parents, your child, your family. Then you have what's called detached compassion. So that's when medical teams work together, or combatants in the army work together. So the situation creates a sense of mutuality and of compassion, of wanting to act on the suffering of the other person. There's compassion through identification. You suffer in a particular way in the same way that somebody else suffered. So I'm also a breast cancer sufferer. I'm also someone who went through the loss of my child. I'm also, right? These are support groups. We call them support groups because you identify compassionately with others who have gone through a similar experience as you have, right? Then there's reasoned compassion. This is compassion based on sort of cognitive ethics. your understanding of the way that you think the world should be. And then there's all kinds of other stuff. I'm not going to go on and on about it. I'm going to let it go. There's non-referential compassion too. We have to explore more what this means, but that's just an overwhelming sense of compassion towards everything without being directed at a person or an object. Kind of a unifying field of compassion, which emerges spontaneously. But the point of bringing all this up isn't to have you memorize a list or to look through the list. This isn't the list. This is a list. The point is that what we do know is that compassion doesn't happen by accident. Compassion isn't the result of some random thing. You aren't either just born with it or you're not born with it. Like, we shouldn't be interviewing medical students to get into medical school who we think are compassionate only. We should be creating the conditions for them to become more compassionate. So what are those conditions? This is one model of the kinds of conditions that have been shown, not perfectly in randomized controlled trials, but still somebody's at least looking, this is again from Joan Halifax, looking at the non-compassionate components that together come together to create compassion. What am I talking about? Give you an example. If you're really hungry and you're freezing cold, how compassionate do you think that you're going to be towards somebody else? Not very, right? Right? So an essential condition to being compassionate would be not having certain things. So you can actually break that down into 4 overlapping areas. So one is the capacity to pay attention in a certain way. So you have to have attentional capacity and attentional focus, first of all, in a certain way. You have to have the right mental framing, a cognitive perspective taking, that when you see somebody who's suffering, you have a cognitive perspective on, well, they're suffering, everyone suffers, and what can I do about it, for example. There's also sort of a somatic framework, right? So this is about grounding your attention in what's actually going on in you at the time. So psychiatrists are good at this in terms of transference and countertransference. But actually, as physicians, it's interesting, we deal with bodies all day long, but in training, we never talk about being aware of our own bodily sensations and emotions. In psychiatry they do, but nowhere else in medicine have I seen anyone talk about what does it mean to notice that your heart is beating really quickly, or that you feel a little bit of a churning in your stomach. That's information. Maybe something's wrong. It doesn't mean you should go with every gut instinct you have, but you should take it as a piece of information that needs to be evaluated. When your hands are sweating and you're walking away from an encounter all anxious, maybe there's some questions you should ask about yourself. Why not tap into that wealth of knowledge? We don't even talk about it. Somehow the body's off limits for ourselves as physicians. So there's a somatic awareness. And then there's awareness of emotions in a particular way also. That's interoceptivity. That's looking at actually the way things feel inside. Anyway, just to say that these large areas come together to form a certain kind of compassion. So it doesn't come out of nowhere. It comes out of these kinds of things, which are things you can do for yourself, train in, learn about, and have active practices for. We can make ourselves more compassionate. The start is, if you're freezing cold and hungry, would be to better eat something and stop being so cold, because otherwise you don't be of use to anybody else. I mean, from what I understand, the Mother Teresa, which isn't much, I don't know, I'm heading into very dangerous territory here, not knowing, I don't know what I'm talking about, but she spent many hours a day with her staff praying. I think that's true. If I'm wrong, you'll tell me, but they spend many hours a day praying, meditating. There's not being with people constantly. You also have to measure how much you're able to be face in front of all that. That takes a kind of wisdom also. All to say that actually, I think wisdom is compassion. Compassion is wisdom. That compassion enacted is wisdom. They're not even different. If you're wise and you enact that and you embody that, you are compassionate. You don't have to strive to do anything. That's what wisdom expressed is. Anyway, that you can argue with me all you want. So what we're going to do now is we're going to watch a 4-minute video. Yay, we're watching TV. So much fun. So I'm going to ask you to pay attention to this video, obviously, and we'll see what you think. So this video comes from the Cleveland Clinic. Some of you may have seen it before. I've seen it many times. I get more emotional every time I see it, not less emotional. We'll see how you feel about it, okay? See if I can play it here. That's not what it's touching, right? But it's not touching because it's shocking, right? It's touching because it's true, right? So if we put bubbles over everybody's heads here, if I could see everybody's bubbles, that's what we'd be seeing right now, right? Over your heads, what you're worried about, your son, your daughter, your this, your that, right? Everybody has bubble over their head, right? that realization that everybody's going through a lot of stuff, right? Somehow we lose that. It's the most obvious thing in the world, and we lose it over and over again when our world closed down into ourselves. And to be compassionate means you have to open up back to that again and again, and there are ways of doing that and of learning that. I just showed you a little snippet of a model for how to do that and how to teach that. And the teaching, it means that we have to do it ourselves. So I'm not saying that we teach it because we're good at it or something. We know what to do, but I have to practice myself. Basically, it's a reopening of the heart over and over again, right? And if I just see the bubbles coming up again, the heart opens by itself, right? So that's what that's. There's even a word, there's no word in the English language for this, but there's been a made-up word, apparently it was a couple of years ago, called sonder, S-O-N-D-E-R. If you Google it, you'll find it, but you won't find it in a dictionary. Sonder. The realization that everybody else is also going through all their stuff. That everybody else also has their full backstory and everything else, right? And the way to tap into that obvious truth, that's where your compassion comes from that kind of knowing. Anyway, so all right. So to finish off here, I think palliative care, so I've taken from the WHO, I've purposely selected for my own nefarious reasons the parts of the definition of palliative care from the WHO that I wanted to show, because it worked for that. There were other parts here that are missing from palliative care. Like it says, to not hasten or prolong life. I disagree with that one. It does prolong life sometimes, so I don't actually want to, I'll put it up there. But the ones I'm telling you on the left, so these things on the left are actually from the WHO, the World Health Organization definition of palliative care. So I'm asking myself the question, then I'll answer the question. What's more irritating than a person who does that? Asks the question, answers the question. I just did it just now again. Okay, relief from pain and other symptoms. Okay, you want that in palliative care. You want that at the end of life. You know what? I want it all the time. I want relief of pain and other symptoms all the time, right? So whole person care, yeah. I want the same thing as in palliative care. How about affirms life in regards to dying as a normal process? Some people may argue, probably not that many people in this room. The public will be like, I don't want to talk about dying as a normal process. Fine, but you know, it's the only thing you know is going to happen. Actually, everything else is up in the air, but you're going to die. People don't want to hear that, but like, hopefully I don't sound cynical to you now or something, right? Probably the right crowd to talk about this. So affirms life in regards to dying as a normal process. Yeah, I want that in my regular medical care too, check mark, right? 3, integrates psychological and spiritual aspects of patient care. Who doesn't want that when you're being treated for your whatever that's serious, right? Yeah, I want that again too. Lives as actively as possible. You're going to argue against that? Are people going to put up placards and go, no, I don't want to live argue? Yeah, I want that too, not just in my end of life care, but I want it all the time, right? Team approach, address the needs of the patient and their families, right? As best as is possible, appropriately as possible, 100%, right? So everything that we say and we hold true in palliative care, and I do hold it true in palliative care, I just don't see any difference from when I'm being the palliative care doctor to when I'm being the ward attending doctor in pediatrics. So I do pediatric palliative care, but I also do general medicine on the hospital wards, like when kids come in with very treatable things that are going to get better, but I'm not like a different doctor or think that I have different values from palliative care from any other time of care. And I bet this resonates with many of the palliative care doctors here who are also family med docs. You know, you don't change your approach. All these things matter all the time. I think, as I said at the beginning, we aim too low. We should be aiming higher in medicine. What we offer in palliative care, you know the palliative care wards, if you've been on them, that you love them and you think they're so great, why aren't all our wards based on those kinds of values? Why do we aim so low? I'm not sure. I think we can aim a lot higher. And so the end of this talk is that this is a future. It's not the future. And as Steven Pinker said, without his permission, I'm doing all this, by the way, talking about him, we can create our future. So I don't want to just passively watch what's going to happen, right? I think we have a role. We're not just passive actors. We can help create the future we want to see. And one of the ways we can do it is by enacting those kinds of things. And we have a book that describes the course. The book is coming out in October by Springer Press. I thank you all for your attention. I wish you a great day. I'll take questions after if you have any.